Good
Okay.
afternoon, our colleagues. Let's start our sixth mixed Viva session, part from our extensive Viva revision course of this week. This is a 13-year-old female patient complaining of gradual abdominal swelling and cyclic pain.
So I'm presented with an ultrasound image of a young female patient who's presented with gradual abdominal pain, which is cyclic in nature. I'm just taking a moment to scroll through the images. Um, I'm just going to ask which area of the body are we imaging? Is that possible? Or is there a marker to see which area of the body this is? I believe it would be the um, abdomen, and I can see a thickened loop of bowel.
This is
But
the
this could
pelvis. Doctor,
it
this
could
is the
equally be it,
pelvis.
sorry, it could
Pelvis.
yeah, pelvis. It could equally be an ovary, which has been slightly thickened. There is an anechoic, mostly anechoic area. Okay. Um, Looking at the second image, I can see that there is a well circumscribed region seen in the pelvis. It is relatively homogeneous and uniform with some internal debris, a bit of posterior acoustic enhancement. I'm just looking and thinking that this would be in keeping with the bladder, but I'm not sure as to um, the exact uh, side. And it also seems to be. Can I look at the last image as well? I see that there's three images. Okay, so this is a ultrasound image of the right flank. I can see that there is um, a relatively uh, homogeneous ovoid shape um, area seen in the center of the image with echogenic bowel wall seen adjacent with acoustic enhancement posteriorly, and superiorly there is a tiny bit of thickening of the wall of this lesion. If this was in the pelvis, I would be concerned with possibly an ovarian pathology. However, this seems like it's also got a shape of a telescoping bowel. So I'm also concerned by possible interception or looking at the image, I am concerned that this could be a thickened appendix as well. I would like to correlate with the area in question. Because it's in the right flank, I'm concerned more about the appendix. And although I can't see, there's a small amount of free fluid adjacent to the lumen of the bowel loop.
Doctor, what's your
Yeah,
next step?
I would like to first inform the clinical finding for my team to make sure it clinically
Mm-hmm.
correlates with the patient's
What else?
symptoms. After that, I would like to compare with any previous imaging if possible. If there is no previous imaging, then I would like to follow this patient up by doing um, in this patient, I'm concerned about the appendicitis, so I'd like to do a CT of the abdomen, um, MRI of the lower limb of the pelvis is also um, useful. So I'm presented with axial slices of the MRI. I'm just gonna, if I can just scroll through these images. Are these static images as well? Sorry. Oh no.
No, rollable.
Okay. Going down to,
Roll, please.
yeah. I'm unable to scroll for some reason. I think, was it yourself that was scrolling? So I can see that, yeah. Okay. Is this you scrolling or is this me scrolling? Sorry.
I, my scrolling.
Okay. Okay. So I can see that there is a high signal, relatively homogeneous region seen in the pelvis. I think there is a connection with the bladder. There is also thickening of the adjacent wall, which is low signal. Do you mind if I can go a bit lower down, further into the pelvis? If that's not possible, I'd like to look at the sagittal sequences. Okay. Okay, it's not associated with the bladder. It's separate to the bladder, and it is got fine thin septae. It seemed to be of the right fallopian tube. Seems quite enlarged. I'm just gonna ask if I can see the sagittal reconstructions. Okay.
What's your differential diagnosis, doctor?
So, with this appearance, I'm concerned with two things. One is possible mucinous adenocarcinoma. Sorry, mucinous mucosal of the appendix with this appearance, and the other differential for this would be hydrosalpinx. Those would be my two differentials.
Doctor, look again, please. Please.
Yeah.
And
Okay.
from the beginning, you forget completely the history that I gave to you.
It's a
See,
cycle.
could
Yeah.
you
So
think, could you think that the appendix can be insinuated like this in between the rectum and the bladder? And
no.
then follow down, 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 down. See, connect something here down to the cranium.
So that would be
Cranium.
the cervix and the vagina and the
So,
cervix.
what's your differential diagnosis?
So I think this is an imperforate hymen, possibly.
Okay. Mm.
So it would be an imperforate hymen with retained products from
Okay, what is the name of this condition?
imperforate hymen.
Yes, yes, okay. Associated with,
Retained. Someone's put in the answer. Hematometrocolpus. Okay, yeah.
okay, excellent.
Yeah.
What
Okay.
else? There are always some associated anomaly. Did you detect any associated anomaly?
I think the anatomy. Just looking for the renal because I'm just thinking. I can't see the. I can't see the right kidney that well, so I think there's
Yes.
an anomaly with the Mullerian
Okay, look
duct,
here.
and
Doctor,
there seems to be also some cystic lesions
okay,
seen in
and
the right flank regions,
okay.
with septae seen extending to the right lumbar region. I'm just thinking if there's anything else that I can see.
So
Uh,
give me your final diagnosis, please.
so it could be Myrotansky, but I'm not sure if that normally has absence of the uterus and the vagina. I don't think that's this case. This could be a Mullerian duct anomaly, of which I would like to just look at the axials once more.
Doctor, we
Yeah.
see almost of the sequence.
Okay,
Give me
yeah.
a final diagnosis, please.
I think this is in keeping with Meyer-Rokitansky syndrome
No,
with
no, no,
malaria.
no.
No,
No,
okay.
no, 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 no.
Mhm.
Doctor, we were in the correct pathway. This is a vaginal or cervical atresia associated with hematometroclopes.
Yeah.
Okay? Roctan, Mullerian Rokitansky syndrome, no, not associated with this signs. It has
Mhm.
some absence of uterus, ovaries, something
Yeah.
like this.
Yeah.
Okay? Thank you, doctor. Did good, but take some messages. Please,
Mm.
my colleagues,
History.
From the beginning, keep the history. I said from the beginning, she has abdominal swelling and cyclic pain. I'm not talking about an acute case.
Mm.
I'm not talking from the beginning. Okay. Then when you see in the axial something like this, okay, follow it. Follow it. See, it is impossible that the appendix reach to this size and then put the appendix inclined to the left like this and completely insinuated between the bladder and the rectum. It is a cystic structure replacing the uterus. At least you can see this polyp. Okay,
Mhm.
follow. Okay, what is this? The appendix has no muscular thick wall like this. Second point, okay, this is the pelvis. See here, this abdomen. See here, there is the abdomen. See here, this is the bowel. Go down. There are cystic lesion here. What is this? This is the left kidney. Where is the right kidney? The right kidney is replaced by this cystic lesions. So this is the cystic lesion. So this is multicystic dysplastic kidney at
Okay.
the right side. Okay, and
Mm.
then there are a dilated tortuous structure from this kidney coming down. This is almost the ureter. So we are dealing with a case of vaginal atresia with hematometroglobus and multicystic dysplastic kidney and ectopic ureter. At least you must give the original diagnosis of this one. Look again, my colleagues, the appendix can't have this thick muscular wall. And if this appendicitis or mucocell, look around, no free fluid, no smudged fat, no anything.
Mm.
Second,
Mm.
remember the history. Remember the history. Okay. Thank you so much, doctor.
Thank you.
Next candidate.
Yes, sir.
Welcome.
CTPNS of an adult patient. There is evidence of diffuse opacification of the right maxillary sinus with the thinning of the walls. No evidence of any cortical break. The left maxillary sinus appear normal. Other ethmoid sinus is normal. No evidence of any mass in the nasal cavity. So, can you scroll a little more, sir?
Okay.
So, an adult patient, the okay, maxillary sinus. Okay. Okay. In the axial view, it appears to be the maxillary sinus on the right side appears compressed by a mass in the right maxilla.
Yes.
The lesion is an expansive lytic lesion with a thinned out margin and no evidence of significant soft tissue component, no definite cortical break. So it's a maxillary lesion causing compression of the right sinus. The lesions in the maxilla, I would like to see the relation of the of the lesion with the dentition. I would like to see the coronal view. The coronal view, it is the molar teeth is seen at the bottom of the lesion. So the possibilities for maxillary cystic lesion, which is appearing non-aggressive, include odontogenic corrective cyst, and
Mhm.
indigenous.
Yes.
Under differential is periapical cyst, which is possible because it is usually associated with the apex of the. But this is related to molar tip, so it is most probably odontogenic character cyst.
Excellent. What's the management?
And odontogenic character cyst. Sir?
What
The
is your
large cyst.
management? What's your management?
I would like to see some any association of the cystic lesion and know the history of the patient. Some it is they are usually associated with some syndromic association like basal cell nevus syndrome. So
Excellent.
I would like, sir.
Excellent.
So I will look for a false cerebral, it is usually associated with false cerebral calcification, and will look at the any history of any skin lesions, and I will inform the findings to the referring physician.
How to
And
how to differentiate it from the indigenous cyst?
the indigenous is usually there will be unerupted tooth
Okay.
related to it. It is it's not looking like an erupted tooth, but
Okay.
this is
How do you differentiate it from adamantinoma?
Adamantioma is usually multiloculated with a little more aggressive, locally aggressive tumor with sometimes soft tissue component also. So it is less likely here.
Could this lesion be mucocell of the right maxillary sinus?
Mucocele is a possibility. First I thought like that, but it appears to be it is not completely
Yes or
related
no?
to.
No. Yes or no?
I would
What is
like
the
to see the
mucocell?
answer.
No.
Mucocele is
Yeah. What is
it's
the
a
mucocell?
retention system. It's a
Yes.
retention system of
Yes.
the sinus. And with the thinning of the wall, the appearance is first I thought of mucocele only in the coronal view, but in the axial view, it appears to be arising from the more closely related to the maxilla.
Look here. The sinus is completely open.
Open. It will be closed in mucocele.
Yeah. Second, the sinus itself, no any expansion or remodeling of its wall. Thank you so much, doctor. You did very, very well. This is a case of a maxillary odontogenic keratocyst. The doctor differentiated from adamantinoma, like she said, and then differentiate from the integer cyst, and even from a maxillary mucocell. In my opinion, my colleagues try to persuade the examiner and tell him your differential and exclude them automatically. Don't let him ask you. Automatically, doctor, I will exclude number one because of 1, 2, 3. Number two, because and my most expected differential diagnosis is like this. Okay, management 1, 2, 3. Okay, like this, the examiner will so impress. Thank you, doctor. So much.
Management, what will be, sir? Correct management of this will be?
What?
Just correct management, what to tell extra? To rule out basal cell nevus syndrome. Otherwise, what else things? Any biopsy to be confirmed, anything like that?
I didn't think this is need a biopsy. Okay, no need biopsy. Just management. It need a maxillofacial referral. At least. Why? They will remove this cyst and they can put a graft from rib from any side, but at least a maxillofacial referral. Thank you, doctor, so much. Next candidate.
Yes, sir. Good evening.
Good evening.
Yeah.
Again,
okay.
This
yes, sir.
40-year-old male patient presented with imbalance memory problems, fever, and insomnia. Okay, this patient has altered mental state with glaucoma of 12. He has no migraine, he has no drug abuse, no autoimmune or systemic disorder. Go on.
Yes. These are the T2 weighted images, T2 flare images, axial sections. Here I am scrolling from the whole set of the images from the top to bottom. Here is the most striking abnormality. I can see that there is a increased signal intensity is noted involving the bilateral medial thalami, along the periaqueductal region
Yes.
around the midbrain,
What else?
and bilateral cerebellum as well. And the pathology involving bilateral symmetrical.
Uh-huh.
Yes. So and the patient is presented with the confusion like symptoms and the bilateral symmetrical involvement of these areas. So I am thinking in the direction of submetabolic cause.
Okay, what else?
That can be, yeah. I will check for the mammillary bodies as well. So because there is bilateral thalami increased signal intensity is there, I will check for any. I will check for the diffusion restriction images, DWI images.
This one. This one. Oh, this one. Yalla, scroll. EDC.
Okay. These are the ADC images, axial sections. I am scrolling from top to bottom. There is diffusion restriction. There is a low ADC value is noted involving the bilateral thalami.
Okay.
And the midbrain area. So and the periaqueductal region, and and also some part of the bilateral cerebellum. So putting it all together in a patient clinical history, this can be the Wernicke-Korsakoff syndrome. That can be the one possibility.
Okay, but look at the cerebellum. Do you think this finding is present in Wernicke encephalopathy? See?
No. Actually, because there is a diffusion restriction is there. So I am thinking in the direction of some acute stroke also.
Okay,
That can be
excellent.
the one possibility. Like vasculitis can cause such type of the
More than
stroke.
excellent. What will you do next? What will you do next?
I will go for the angio. I will inform. This is urgent finding. I will immediately pick up my phone and urgently inform the finding to the stroke team, and
Okay.
the angiography can be done.
Go on. Hello?
Hello, this is scroll level image, sir, or this is static image?
Static.
Hello, static image. So static, yes, sir. So here I am going. This is most likely the vertebral artery.
Okay.
And this is the basilar artery, and then from the basilar artery, because there are many lesions in the midbrain pons and the cerebellum. So I am thinking that there is some artery that is arising from the basilar artery that may be involved, that leading to the leading to the such type of the images. There is diffuse narrowing is noted on the left side, but I could not identify which vessel is this actually. But on the left side, there are more changes are noted, and there is a paucity of vessel is noted in the central part of this.
1 second, listen.
This can be the superior cerebellar artery.
So what's your diagnosis?
So this there is a diffuse narrowing of vessels is there, so that can be vasculitis involving the posterior circulation. That is my main diagnosis in this case.
Okay.
With the top of basilar syndrome that can causing such type of the images.
What you mean by basilar syndrome?
There is a basilar artery thrombosis is there that can involve the bilateral thalami, midbrain, and the cerebellum. Acute strokes are
Amazing,
there in that condition.
amazing, doctor. You did very, very well. You are more than excellent. Thank you so much.
Thank you, sir.
This is
Thank you, sir.
one of the fantastic case that I have presented in my session at all. Why? See, my colleagues, the quality is bad. And maybe you presented with something like this because we face these artifacts in our life and we should report in some cases. Especially the finding is clear. See here, he start from the basal ganglion. He start bilateral nearly symmetrical medial thalami, abnormal signal. And then he search here around the aqueduct of syllabus, maybe some signal abnormality. Then he started to talk about the thiamine deficiency, vitamin B6, B6 or Wernicke encephalopathy. Okay, but we should examine the whole slice. When we go to the posterior fossa, our pathway extremely changed. Look here, multiple bilateral cerebellar abnormal signal. When we go to the diffusion, it looks like strokes. See, very restricted strokes. And it looks like in territorial distribution. Doctor, I didn't know what this territorial. No problem. At least they are conglomerated in one sectorial. And if you see here, looks like triangular or wedge shape distribution here. So it almost territorial. So we are dealing with vasculitis. When you see multiple scattered strokes like this, okay, think in vasculitis. But the point here, what is this? Is this inferior sagittal sinus thrombosis? Is this vascular basilar artery occlusion, or is this artery of Percheron occlusion? Okay, all the possibilities are leave the mouse, please, doctor. All the possibilities are still suspected. So he asked the angio. When we did the angio, see, my colleagues, this is not the normal vertebral artery angio. Why? Really, because there are paucity of main arteries, and the main arteries like superior and inferior cerebellar, ica are reduced. In image like this, don't concentrate to tell the examiner, oh doctor, the ica is not seen, the bica is well seen. No, first of all, look for the image overall. Oh doctor, the vessels is markedly attenuated, all the vessels, and then it looks like many collaterals around it, and this artery looks like vented. So this is vasculitis. The examiner will be so happy. He will appreciate your style so much. Okay, my colleagues. So it is a case of vasculitis with artery of Percheron. Why? Why? Because the bilateral symmetrical medial thalami affection, medial thalami stroke. Okay, my colleague. Even our colleague, he told me this is occlusion. Okay, no problem. Basilar artery occlusion, no problem. But he is in the pathway, in the correct pathway. Thank you, doctor. You did very, very well. Next candidate.
Hello, sir.
Hello. Request control. 40 years old female patient complaining of severe dysmenorrhea. Go on.
Okay. I have been provided with sagittal T2 images of a pelvis of an 48-year lady who was presented with a complaint of dysmenorrhea. I'm scrolling through the images from I can see the uterus appears enlarged in size,
Okay.
and there is there are multiple hypoattenuating area lesions noted within the myometrium of the uterus.
Where? Where? In which part of the myometrium? In which
It is
region?
on the anterior aspect,
Mm-hmm.
and also on the posterior aspect. These are suggestive of fibroid. Um, Apart from that, the junctional zone appears slightly widened. However, I could not find any T2 hyperintense cystic lesion within the myometrium. Um, Apart from that, I'm looking at the cervix, which appears normal to me. Looking at the other area, I can see there is evidence of a T2 hyperintense lesion within the adnexa. Uh, I will confirm it on the axial images to further characterize it. Um, there are few Nibothian cysts are noted within the cervix.
What's your differential diagnosis, doctor?
Can I look the axial images of this patient?
No, tell me first. This sagittal is very conclusive. At least give me one or two findings.
First, I am thinking of multiple fibroid within the uterus. Um,
Okay, what else? Go back, back. Stop here. What is this? What is this? Leave the mouse? Leave.
yes,
Leave. What is this?
sir, I
What is
cannot
this?
see you.
This?
Sir, I cannot see your cursor.
This at the posterior wall. What is this?
Sir, I am not able to see your cursor, but
Okay, look at the posterior wall. Describe.
yeah,
Give
the
me
posterior wall appears to be slightly thickened with replaced by a hypointense area within it.
yes. Where is this hypointense area? Where?
It is appears to be within the myometrium.
Exactly, most likely where? In which part? See, this is the endometrium, and this is the myometrium. It almost between both of them. What's the name of the area between endometrium and myometrium?
The junctional zone.
Yes. So what is this?
It appears to be thickened and
Mm,
irregular.
yes,
So
yes. So what's your diagnosis? Second,
adenomyosis.
yes, very easy. Dr. Roshni,
Yes, sir.
you have too much knowledge in your brain. Okay? don't hesitate. You are correct. From the beginning, when you are starting, you are talking about this, and then I perceived your hesitation. Okay? Don't hesitate, you are correct. This is the axial T2. Continue, please.
Yes. So these are the axial T2 MRI images of a patient. I'm scrolling through the images. Here are Nabothian cysts noted within the cervical region. Again, I can see the junction zones appears to be irregular and thickened.
Okay, خلاص. Don't worry about it. What else?
Okay. Looking at the adnexa. There is a hyperintense lesion noted within the left ovary. There are peripherally arranged follicles are present. Also, there is another area which showing a fluid fill level in the left
Excellent.
index.
So
I
what's
will
what's
confirm.
your diagnosis? No. What's your diagnosis in this point? After
This
describing,
can be
give
this
the
can be
examiner any
endometrioma
possible. Yes.
or other hemorrhagic cyst, less likely, but can be in the differential. I will look at the T1 fat set image to see whether it is not in hyperintense and not suppressed on the.
T1 fat set. T1 fat set.
I'm trying to see the same area. There is a level is noted. It is hyper. It is not low.
One
It is
second.
hyperintense.
1 second. What is this? What is this?
There is a enhancing area noted within the ovary.
So what is it? What's your diagnosis?
It is in a focal area. I would like to see the T1, whether it is present on the T1 weighted images.
Roshni, 1 second. Take a deep breath, please. 1 second. This is T1 fat set. And you ask it by yourself to confirm something. Is this confirming your diagnosis or not? Yes or no?
Yes, it is confirming that it is endometrioma.
Why?
It is not suppressed.
Why? No.
Because it is again showing up.
No. Come back. High T1. Leave the mouse. High T1 signal in T1 fat set. What does it mean?
It is a hemorrhage.
Okay, not fat. So
Yeah.
You should think in this way. You ask me, you request T1 fat set, and I give you. After that, give me your feedback. Okay? What else? What else? Look here. What happened here?
Um,
1 second. Use the mouse.
yes.
It is a little bit difficult, yes, by the way. What happened here? Look here. What happened?
Sir, something arising from posterior wall of the uterus.
Okay. Excellent.
Okay, I can see there are hypointense area also noted around the rectum. This could represent
Yes.
endometrial implant.
Excellent. So, what type of endometriosis this one? This, by the way, are fibrotic bands. So we are dealing with which type of endometriosis?
Oh,
Which
I'm not
type?
sure, but these are the endometrial implants.
Okay, excellent. Thank you, Dr. Roshni. You did very well. Please trust in yourself. When you see something, your eyes send something to your brain. Please don't stop the stream of information from brain to your tongue. Why? Because Dr. Roshni first open this and she started to talk about this. Okay? And stop. Why did she stop? Because she hesitated. This is a junctional zone. Second, facial posterior. Almost this adenomyosis. Very easy. Second point, this one. What happened at the left adnexia? There are at least 2 or 3 cysts with 2, and I think this 3 with fluid level. Okay? And this fluid level very dark inferiorly. Very dark. So you must expect endometrioma, especially with adenomyosis. If you look here, there are a fibrotic, see? There are a fibrotic band, very large, see? Very large, between the rectum and the posterior wall of the uterus. Why? This is because of deep pelvic endometriosis. This sign, I see, fibrotic band from here the rectum, to the uterus, to the left adnexia. It could be a clover leaf sign. The deep pelvic endometriosis, my colleagues, take one of two signs. See the fibrosis. See it يعني, can you imagine it cause a cross-like fibrosis, and it cause tethering of all the adnexia to each other. So this is a clover leaf sign. Okay, the deep pelvic endometriosis take one of two signs: either high T1 implantation, where is the most common site of implantation of this endometrioma in this ligament? Uterosacral ligament. This one, this is the uterosacral. But here the ligament is very smooth, very thin. There are a cutoff point. This ligament maximally measure 5 mm. But when it has become nodular or high T1 signal or more than 9 mm, you should suspect a deep pelvic endometriosis. This is the common site. Second, this fibrosis. Okay. Third, sometimes, especially in sagittal, in coronal, sorry, we don't have coronal here. You see both ovaries closing to each other, casing ovary sign. Why? Because the fibrosis occur here, so it causes attraction or tethering of the ovaries to each other. So the ovaries looks like kissing each other. Okay, so this is a case of a deep pelvic endometriosis associated with adenomyosis and some fibroid. My colleagues don't expect in the exam he will give you one case for just only a fibroid. Okay, my colleague, look here. Look for the fibrosis. Look. Very characteristic. Okay, my colleagues. Thank you, doctor, so much. It was a difficult case. Next candidate. Welcome.
Hello.
Next candidate.
Yes, hello, doctor.
Before I start this case, there are a very common sign during the ultrasound to rule out deep pelvic endometriosis. This sign called sliding sign. You make some gentle pressure at the probe, the vaginal probe. The uterus should move up and down with you. But if it is fixed to the rectum posteriorly, this sliding sign is negative. What means negative? Means the uterus is not movable. So there are a fibrosis. This is an ultrasound finding. Keep in mind, I think this is not too much important the exam, but in the same street. Welcome, doctor. 5-year-old male patient with respiratory distress. Go on.
Yeah, so this is a chest X-ray frontal view. I can see that there is a left upper lobe increased attenuation. Hyper translucency with internal septations and bulging contour, a convex contour. It shows it has a mass effect, shifting the mediastinum to the right side, and indenting the lower loop. So and there is no pneumothorax. There is no bony, no obvious bony lesions. The cardiac shadow appear unremarkable. So I can't see the stomach gas bubble, but
what's your diagnosis, doctor? Doctor, what's your diagnosis?
My first possibility is my provisional diagnosis CPAM, congenital pulmonary airway malformation.
Why?
Um,
Why?
this is the most common location.
Doctor, what happened?
And
Sissy, one second. What happened? What happened? What happened here?
it's
Where is the
there
heart?
is air
Sissy, where?
trapping.
Yes, okay, okay. Where is the heart and the trachea?
Shifted to the right side.
Okay, so what happened
That's
here?
okay.
What happened here?
Hyperinflation.
Okay, give me differential
Okay.
diagnosis according to
Okay.
the age.
Okay. The second is okay, congenital lobar emphysema also.
Okay, versus
Yeah.
versus
with these septations,
no septation, doctor.
the CPAM. Okay.
No septation, and the CPAM will not cause this hyperinflation. What is the most common cause of hyperinflation in pediatric age? Number one, congenital. Okay.
James and air and foreign body inhalation.
Okay, okay. Like this, you are in the correct pathway. What will you do next?
CT.
Okay, okay. You requested control?
Oh, sorry, doctor. I can't control this from my
Okay.
mobile.
Yeah, go on.
Okay. So this is the CT chest. Lung window shows there is air trapping and hypertransfugency of the left hemithorax with paucity of the or attenuation of the pulmonary vessels.
Which lobe? Doctor,
Sparing the it's in the upper lobe.
Yes. So
Sparing
give
the
me a
left
diagnosis.
lobe. Okay, so this is most probably Swire James.
Doctor, doctor, 1 second.
Okay,
There are
Swire James most probably will be
hyperinflation.
okay. Will be a smaller small lung.
Yes.
So this will be most probably congenital lobar emphysema.
Okay.
My first possibility.
Why it is not a foreign body? Why? Did you
Okay,
inform
so
the examiner?
I would like to check. I would like to check the bronchi as well to just
Check.
rule out.
Check.
Is there any? Okay.
Did you find anything?
So there is no there is no radio big foreign bodies.
Yes.
So because of the pulmonary arterial attenuation.
Doctor, give me your final diagnosis. What is your final
congenital
diagnosis?
Congenital lobar emphysema.
Thank you so much. Thank you.
Okay.
My colleagues, as you noticed today, there are a fluctuation of the cases that I bring. I bring one case like this, very direct case, okay? And I bring some cases out of the box, some cases moderately difficult, and something like this. This is the actual scenario. And do you think that most of the EC cases, most of us are struggling with it? Why? Because we are thinking about the most rare, the most difficult, the most unexpected diagnosis. No, every session I am telling you at least 60 or to 70% of the cases is very typical, very, very typical. Like the case you can smash within 1.5 minutes. Okay? This case, our candidate know it well, but she are asking herself, I suspect she has a conflict in her mind. Ew, is this so easy like this? No, there may be some tricky inside it. No, try one by one. Try step by step. What if I am presenting with this case? What I will do? What I will do? The X-ray hyperlucency here, plus shifting to the contralateral side. So hyperlucency mean 1, 2, 3, 4. But which pathology is related to the hypertension with contralateral shifting, the foreign body or congenital lobar emphysema. So when I am searching and I am looking at the CT, I'm looking to exclude something from the beginning. What to exclude foreign body? So your eyes only on the bronchi from the beginning, no foreign body. Oh, okay. So this is not foreign body. Then I'm looking to the lung. Oh, okay. This is affecting only the left upper lobe. So, doctor, this is a left upper lobe congenital hyperlucent lobar hyper emphysema. Congenital lobar emphysema. What will you do next? I will transfer to pediatric chest. Why? If he asks you or if you want, doctor, in these cases, they almost remove this loop because it causes some dyspnea, some respiratory problem like this. 1.5 minutes, the case is smashed. So when you are looking to an axial, ask yourself what I'm wanting from this sequence. Okay? What I'm wanting, you want here, in this case exactly, to rule out foreign body from the beginning. Okay, my colleagues? Thank you, doctor, so much. Next candidate.
Hello.
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 Yes, hello, doctor.
Yes, sir.
Can you hear me?
Yes, sir, I can hear you well.
Yes. Go on.
Okay, this is, I think, no previous for comparison screening study, no comparison, previous for comparison. So
Yes.
this is mammography craniocaudal projection of the right breast.
Yes.
With screening patient having adult patient came for screening. There are multiple densities. There are multiple rounded densities. They have one sharp border that is outlined by the ear, and the second border is obtuse. So likely these are involving the central and the lower quadrants, inner quadrant of the right breast.
Okay.
They likely represent some skin lesions, skin tags.
Excellent.
So I will confirm these on the mediolateral projection, and on the mediolateral oblique projection confirms their presence, their relationship to the skin. They are involving the upper and the lower quadrants also. Likely these are upper inner quadrants of the breast, upper inner. Besides these three major lesions, I can also appreciate multiple other smaller lesions in the breast parenchyma. I